Essential thrombocytosis is a rare blood disorder whereby
the bone marrow starts to make too many platelets, and as a result of that, in turn, people are at increased risk of blood clots.
But while it is a serious blood disorder, it's also very treatable.
It is a serious condition, but many times it's compatible with a normal life. Normal life expectancy, normal quality of life is one of the ones that are very manageable.
And later, hear from someone who's living with it and thriving.
Right now, I just feel good. All of my blood work is fantastic. Even my blood counts, those are within normal ranges.
Discover In the Blood, Essential Thrombocytosis, inside this edition of CTSI Discovery Radio. Welcome to CTSI Discovery Radio. I'm your host, Brian Belmer. CTSI Discovery Radio is brought to you by the Clinical and Translational Science Institute of Southeast Wisconsin. The CTSI is a consortium of researchers, doctors, scientists, and others representing 8 institutions, including the Medical College of Wisconsin, Milwaukee School of Engineering, Marquette University, the University of Wisconsin-Milwaukee, Children's Wisconsin, Froedtert Hospital, Versity Blood Center of Wisconsin, and the Zablocki VA Medical Center. The CTSI works collaboratively across all of our member institutions. Our mission is advancing health through research and discovery. The importance of having healthy blood cannot be overstated, as it's responsible for delivering essential nutrients to our body, removing waste from our body, and fighting infections throughout our body. It's easy to take healthy blood for granted, but the reality is there's no substitute for it. Today, we discover one blood disorder that can compromise a person's health and how it's treated in order to maintain quality of life. For this, we get expert insights from Dr. Michael Deininger, Professor, Department of Medicine, and Associate Dean for Research at the Medical College of Wisconsin, and Executive Vice President and Chief Scientific Officer at Versity Blood Center of Wisconsin. Our conversation begins with Dr. Deininger first explaining what this condition, known as essential thrombocytosis, commonly referred to as ET, is.
ET is a condition where the bone marrow, as a result of mutations in the DNA of stem cells, starts to make too many platelets. And as a result of that, in turn, people are at increased risk of blood clots.
Now, you may see this condition also referred to as essential thrombocythemia. Is there a difference?
It's totally the same. It's just used by various people. So essential thrombocytosis is one, essential thrombocythemia, but there is no difference.
Understanding that ET is a disorder related to blood clotting, Dr. Deininger explains what's happening biologically in the blood of a person afflicted with this disorder.
Let's start with the marrow. All the blood cells are made in the bone marrow. So there are platelets, there are red cells, there are white cells. And normally the levels are kept within very narrow limits. But sometimes stem cells in the bone marrow acquire changes in their DNA, mutations. And as a result of those changes, the balance is lost. So the marrow starts to make too many platelets.
What are platelets, and why are they a critical component of our blood?
Platelets are just very small blood cells, and they are critical for stopping bleeding when we cut ourselves, for instance.
In other words, platelets are a key component for the healthy clotting of our blood. However, the downside to that is
if you have too many of them, or if they behave in a way, they can also cause blood clots where it's not needed.
Which, in turn, can manifest in some very real, very serious related conditions, including
stroke, heart attack, deep vein thrombosis. So that's the morbidity, or that's the problem associated with ET.
Is essential thrombocytosis a form of blood cancer?
If you don't beat around the bushes, it is a form of blood cancer. It tends to take a very chronic course, though, so a lot of patients are stable over many years.
But Dr. Deininger says it can change with time, typically in one of two different directions.
One direction is that patients with ET have a higher risk of developing acute leukemia. So we estimate that maybe 4% of ET patients will eventually develop that.
And the second direction is
over time, the bone marrow can become very scarred, and we call that fibrosis. And eventually, it can actually lead to a failure of the bone marrow to make enough blood cells. We call that myelofibrosis.
the point is, a patient's essential thrombocytosis is not always stable.
So it can evolve over time and essentially turn into these other conditions.
However, Dr. Deininger is quick to point out this isn't the key problem.
All things considered, the key problem really are the blood clots, because they can cause a lot of damage. Somebody has a stroke that can be irreversible. Somebody has a heart attack that can be irreversible. So the first call to action is to make sure that we minimize the risk of these blood clots.
On the spectrum of blood diseases, how does a condition like ET rate?
I think ET, considering all other types of blood cancer, is one of the ones that are very manageable. It is a serious condition, but many times it's compatible with a normal life expectancy, normal quality of life.
Which means, by and large, patients with ET can continue to participate in their normal activities and life experiences.
I think for all practical purposes, yes, because the available medications to control the high platelet counts are typically pretty well tolerated. Exceptions here and there, but I think altogether this is a manageable condition that is compatible with a good quality of life.
Next, what causes ET? Is this an inherited or genetic condition?
There are some cases where ET essentially runs in families, but that's the exception. In the majority, it is a genetic accident. So a stem cell in the bone marrow happens to acquire a mutation in the gene that is then increasing the output of platelets. There is no, as far as we know, no really well-established risk factor for that. So it's, for most purposes, it's sporadic.
And he says it's a blood condition that's been known for quite some time.
ET has been known for a long time, but I think people had a hard time to distinguish between ET and what is reactive elevation of the platelet counts.
He explains what the difference is.
Platelets are interesting cells because they can respond to a number of different conditions. For instance, if you have iron deficiency, then the platelets tend to rise. Or if somebody has an infection, platelets tend to rise. So distinguishing between that and ET hasn't been possible for a long time.
Because while ET was first diagnosed back in the 1950s,
A guy by the name of William Damashek realized that all these disorders that have increased platelets or increased white blood cells, they all have something in common. And so he coined the word myeloproliferative disorders. The bone marrow pushes out too many cells. That is the invention of ET as a disease entity. But as time went by, people started to understand that high platelets are not always caused by genetic lesions. But what these genetic lesions were, we didn't know for a very long time.
in fact, it wasn't until
2005-06 when people applied technologies to understand the genetics of myeloproliferative disorders, including ET. And then they found mutations. And from that point on, we were able to distinguish between what we call reactive thrombocytosis and ET.
just how prevalent is ET?
The estimated prevalence is 2 to 3 per 100,000 per year, give or take, because there's sometimes uncertainty about the diagnosis. All in all, it is a rare condition, but it does affect certainly several thousand of individuals in the United States. And since the life expectancy is long, the prevalence is quite high.
As far as how diagnoses of essential thrombocytosis are typically made,
Essentially, there are two ways to get diagnosed. One is to have some kind of complication, typically a blood clot, a stroke. And then people do blood counts and they find the elevated platelet count, and then diagnostic workup leads to a diagnosis. And it is very common nowadays, as people have their annual checkups with a complete blood count, that an elevated platelet count is discovered. If that is repeatedly seen, people get evaluated and a diagnosis is made.
what symptoms could a patient experience if they have ET?
So if it's clean ET, not progressed to anything else, people may complain about TIAs, transitory ischemic attacks, mini stroke. So, for instance, you might lose vision in your eye for a minute or two, then it comes back. Or you may experience tingling and weakness in your hand, and then it goes back to normal.
Other common symptoms might include
Tinnitus, basically your ears ringing. Some people will get very cold fingers. Basically, the tips of your fingers will turn blue. They can be painful. All these symptoms have to do with the blood flow to certain areas being impaired.
and there can be more serious symptoms, such as
A real stroke or a real heart attack or deep vein thrombosis that leads to permanent organ damage. And some people will get diagnosed because they have this significant event.
are there people diagnosed without any discernible symptoms?
I think that happens many times. As blood counts are done on a more routine basis, you pick up somebody with an elevated platelet count. But the question is that ET or is it reactive? Many times people come back in a couple of months or so and see the platelet count is still elevated. And if it's still elevated, you initiate more diagnostic steps to distinguish between reactive elevation of the platelet count versus true ET.
Which means when it comes to diagnosing ET in some patients,
Well, it can be difficult. A lot of our diagnostic workup is now based on genetic testing, a mutation test, and maybe 90% or so of the true ET patients, that mutation test will come back with 1 out of 3 typical mutations we find. But there are about 10% of patients who have none of these typical mutations. And in those patients, it can be tough to distinguish between ET and a reactive condition.
are there effective medications to treat ET?
First of all, we do some risk stratifications very much based on what is the risk of having a blood clot. And there's almost universal agreement that aspirin should be given because that is very low risk and high gain. Aspirin has been shown to reduce the risk of blood clots.
For patients at higher risk for blood clots,
You've got to think about whether or not you need to lower the platelet count. And there are several types of platelet-reducing therapies, but they will not restore the normal bone marrow. They basically control excess platelet growth.
another option
Is a substance called interferon, essentially a hormone the body makes in response to infections and other inflammatory processes. But quite a few patients with ET respond to interferon. Interferon can lower their platelet counts, and in some cases, the mutations tend to get lower or sometimes even disappear.
While these different treatments can be effective,
Each of them has advantages and disadvantages. So what I'm saying is that you have to consider the patient's situation in a holistic way and then decide the best approach to treatment. There's not a one-size-fits-all.
can a person's ET ever go away or at least into a state of remission?
The current wisdom is you are likely to have it for the rest of your life. For the majority, the reality is that you can't get rid of it. So there is not yet a cure available for the majority of patients.
But ongoing research hopes to reveal more discoveries.
There is a lot of research going on in myeloproliferative disorders in general, and ET is included, but we need to do more. We need to better understand what makes these cells different from their normal counterparts and how could we leverage that knowledge to target them. So there is a need to do more research.
For anyone living with essential thrombocytosis,
if you have a diagnosis of ET, life doesn't stop. This is a manageable condition. It may require treatment, it may require lifestyle modification, but if you do all the right things, your chances of having a normal life are actually pretty high.
and you can rely on the knowledge that
Life goes on because this is a manageable condition, and I think this is not the end of the world. So move on.
next, we discover someone who understands exactly what Dr. Deininger means, because she's doing exactly what he said, moving on after being diagnosed and now living with essential thrombocytosis. Let's meet her now.
I'm Chris, born and raised in Wisconsin, currently living on Okauchee Lake, 2 years now retired, and we are just enjoying retirement.
In retirement, leading a pretty active life.
Being on the lake, we like boating. We're the first on, last off, enjoying even into the fall weather. Love it.
And when not traveling by lake, then by air and land.
Traveling is a huge part of our activity. My husband says it's almost a little too much travel, but I still get him to go. Traveling around Wisconsin, that's been our thing, going to supper clubs and exploring what Wisconsin has to offer. And we spend as much time as we can with my stepkids.
Basically, living an active life, doing all she can while she can.
We're very active compared to a lot. I honestly do not think that I have ever been happier. Yeah, life is good. I feel very fulfilled.
In general, Chris says her health is good.
I think that I'm actually quite healthy. We try to eat well, try to balance healthy eating with, fun celebrations. I'm not going to not have a piece of cake at the wedding or anything like that, but we really try to be healthy and active.
Although she shares that through her life, she's had some relatively minor health-related challenges.
Yeah, I've had asthma when I was very young, and then it seemed to resurface. So, being outside became an issue, especially when we would go hiking. I had my gallbladder out. That was the extent of my health issues.
Now, another activity Chris has been committed to for much of her life is donating blood.
It actually started with a girlfriend of mine. We were getting together and we'd go have drinks or dinner, and we talked about, what else can we do? We decided that before we would go for dinner, we wanted to do something more, and that was giving blood.
She knew it was important for those who need it, but she also discovered donating blood was,
it was so fun. I know that's really bizarre, but it was just fun for her and I to go. And it got to a point where the employees at the blood center knew us, and we would talk to them, and we'd start our catch-up, and then we'd have our snacks afterwards.
Chris found she not only enjoyed donating blood,
I just really like the cause. It saves lives. It's so critical. And before we left, we always made an appointment for our next get-together. So we probably went once a quarter, so 4 times a year. And then Harley, where I worked, often had blood drives, and so I just added that to my regimen.
but while she donated blood to save the lives of others, turns out it may very well have helped save her own.
When I was first notified that my platelets were high, i.e. over the 450 level, so the normal range is between 150 and 450, it was when I donated blood. So I was surprised. It was like 500. So I did go see my doctor. I didn't feel anything. I felt perfectly fine, normal. So that's why she said, let's just monitor it.
However, before too long, she did start to feel symptoms of something.
I started feeling, I don't know how to describe it other than it felt like jet lag. For anyone who's traveled and knows what jet lag is, it's not like I want to go to sleep, just tired, kind of lethargic. I couldn't concentrate, a little nauseous, but my best correlation was to jet lag.
Causing her to wonder what was going on.
You know, it was post-COVID, and I didn't know if I was just feeling tired because of getting older. I think a lot of us always attribute a lot to getting older.
And while her primary physician monitored her, these symptoms persisted for several months.
She was monitoring it, and I had said I wasn't feeling great. We retested every 6 months, and then my platelets kept increasing, so that's when she recommended that I see the hematology oncologist.
Were her symptoms impacting her quality of life in any specific areas at this point?
Only in terms of work. It was hard to concentrate. That would be my biggest. I just had less energy.
As mentioned, Chris's primary physician referred her to a hematology oncologist.
Because my platelets continued to increase, like from 500 to 600 to 700 and 800. So when I saw this oncologist, he reviewed my history and recommended that I had a bone marrow biopsy.
Which she did have. The biopsy confirmed a diagnosis.
Essential thrombocytosis.
The biopsy is also utilized
To test for 2 known gene mutations, because there's different reasons that your platelets can be high, but specifically they check for the mutations.
What did her biopsy reveal?
It showed that I was positive for a mutation called CALR exon 9. Then they could definitively diagnose it and thereby treat it appropriately.
How was the CALR exon 9 mutation explained to her?
It is the mutation where my platelets don't stop getting created. There's 2 different mutations typically, CALR and JAK2. My doctor described it as CALR is the less sticky version and JAK2 is the sticky version, which means the platelets don't stick together as much and form blood clots.
So, the relatively positive aspect of her diagnosis is that
If you have to have one or the other, the CALR is better because most people typically have a normal life expectancy.
But this didn't bring much comfort because
Even with saying it's a normal life expectancy, I don't know what that truly means. Normal life expectancy for someone with a blood disorder, I don't know.
what Chris did know was being diagnosed with a blood disorder is nothing to take too lightly.
It is scary, yeah. Very scary. And at that time, before I had results, you go to Google and you're like, oh my gosh. Fortunately, I have a husband who is my calming factor. It'll be okay. But it's scary.
Still, although it was indeed scary,
To be honest, I was thankful that I had a diagnosis fairly quickly and felt very hopeful that this particular blood disorder has a treatment. The scary thing for me was to continue to feel, not myself. So I actually felt hopeful that I was going to feel better.
how is Chris's essential thrombocytosis with CALR exon 9 mutation being treated?
So immediately they put me on a daily baby aspirin, so 81 milligrams, to reduce risk of blood clots, which can cause stroke or heart attack. And then we were just going to check every 3 months.
Unfortunately,
The platelets were trending in the wrong direction from 500 to 900. That's when we started talking about the most commonly prescribed drugs for this diagnosis, hydroxyurea.
but this initially caused some concern for her.
Reading about hydroxyurea was scary. It is a chemotherapy drug, like to think that I'm on chemotherapy for the rest of my life. Reading about side effects, leukemia is listed as a side effect. So obviously the hydroxyurea is doing all sorts of things to your blood. It's reducing my red blood cells. It's reducing my white blood cells.
Then, Once she began taking the medication,
That's when I had this burst of extreme fatigue where I don't think I could have been working. But that weaned as I got used to the medicine.
which is fortunate because the reality is
Hydroxyurea has been used for decades for blood cancers. It really reduced platelets, so that has been the common treatment.
since beginning her treatment with hydroxyurea, has her health improved?
2 years in, I'm still not at platelet count in a normal range. It's definitely a process. So I started with one 500 milligram pill of hydroxyurea. That didn't seem like it was doing much, so they increased it to 2. And then just recently, they increased it to 3 500 milligram pills per day.
How has that been working?
When they initially increased it, I was almost bedridden, but I have found after 2 times of increasing it, it does get better. I do get to a point where I feel good once my body gets used to that dosage.
And that's key because, ever the optimist, Chris says,
Right now, I just feel good. All of my blood work is fantastic. Even my blood counts, those are within normal ranges. I think the biggest thing, if I ever do feel anything, is just a little tired. But other than that, I'm like, oh yeah, this is what good feels like. It makes me very happy.
although there is one significant way her life has been interrupted since her diagnosis.
Unfortunately, I couldn't donate anymore. They will not take my blood. And I was very sad about that. I really enjoyed that.
Instead, Chris found another way to give something to the community.
Instead of giving blood, now I give meals. Doing Meals on Wheels. That's my giving back to the community instead of giving blood.
It's something she hopes others will do since she no longer can.
I truly believe that giving blood saves lives. It's so important. I think if anybody can, they should. It doesn't matter what kind of blood type you have. It can all be used and save someone's life. I think that's amazing. And it's so easy.
And the soft-spoken Dr. Deininger speaks this hard truth.
Modern medicine is simply inconceivable without blood donations. So please consider that strongly and donate blood. There is no replacement. Humans are the only source. So everybody who comes for blood donation should be aware that they make a really critical contribution.
Chris also knows now living with a blood disorder is manageable. And she stresses not only is her blood disorder treatable,
It is treatable with an inexpensive, effective drug, and you can have a normal, long life with it. A lot of people dismiss, ignore, are afraid to find out that something's wrong, but finding out this diagnosis, while it sucks and it's scary, it is treatable.
a positive, powerful message. But now we're all out of time for this edition of CTSI Discovery Radio. As always, thanks to our guests for appearing on today's show, Dr. Michael Deininger, and special thanks to Chris for sharing her experience. I hope you've discovered something by listening to today's show, and I'm doubly hopeful that you'll join us again next time. CTSI Discovery Radio airs the third Friday of every month. Make an appointment on your calendar and join us for each episode. On behalf of the Clinical and Translational Science Institute of Southeast Wisconsin and all of our affiliate partners and members, I'm Brian Belmer, wishing you happier, healthier days ahead. For more information about research or to listen to the podcast of this or any of our shows on demand, please visit our website at ctsi.mcw.edu. CTSI Discovery Radio is written, produced, and hosted by Brian Belmer in collaboration with WMSE Radio. The CTSI and this program are under the direction of Dr. Reza Shakir.